This is Heliox, where evidence meets empathy. Independent, moderated, timely, deep, gentle, clinical, global, and community conversations about things that matter. Breathe easy, we go deep and lightly surface the big ideas.
Welcome back to the Deep Dive. Today we are taking on, well, a truly massive topic, one that's been surrounded by confusion and, frankly, a lot of fear for decades. We're talking about menopausal hormone therapy, or MHT.
It really is, and it's arguably one of the most publicly debated areas in all of women's health. You're looking at a huge amount of really complex data. We've got these landmark trials, we've got sophisticated risk assessments, and the core problem is that the headlines from one infamous trial just completely overshadowed all the nuance that came after.
That's the exact complexity we want to get into today. We've pulled together a really powerful stack of sources. Current international clinical guidelines, the latest research looking at high-risk populations, and a very sharp critical assessment of the recent media narrative around MHT. Okay, let's unpack this. Our mission here is to cut right through those decades of fear and misinformation. We want to give you the definitive evidence-based roadmap for how MHT is prescribed today, really focusing on the science of individualized care over those old, sweeping generalizations.
And before we get into the data, we need to set a clear foundation. Menopause is a specific biological event. It's the moment a person has gone one full year without a menstrual period.
And the median age for that is 51.
Right, 51. But the experience, the years leading up to it, that's called perimenopause, and that transition can, believe it or not, last for up to 10 years.
And that's where the problem really starts. When we look at the clinical reality, the biggest obstacle to good care is, well, it's twofold. First, there's this persistent, sometimes really irrational fear of the risks among patients.
And the second part is a lack of up-to-date knowledge among some doctors.
Exactly. And that combination means patients who are really suffering just don't get the most effective treatment. Our goal today is to completely reset that foundation of knowledge. So when we talk about menopausal symptoms, it's so important to be clear, we're not just describing some mild passing inconvenience.
No, not at all.
We're talking about symptoms that reflect this incredibly complex web of, biological, psychological, and even social factors that can just completely erode a person's quality of life.
Indeed. The transition is natural, of course, but the symptoms can be debilitating. The ones everyone talks about are the vasomotor symptoms, or VMS.
Hot flashes and night sweats.
Right. And they are just staggeringly common. We're talking up to 80% of women are affected during that perimenopausal or menopausal phase.
80% is a massive number. And what really stands out in the research is how long this can last. You often hear it's just a few years, but that's not the whole story.
It's not. While most VMS do resolve within about 7 years after the final period, the data shows a quarter of women, 25%, experience flushing for up to 10 years.
And a full 10% go on for more than a decade. I mean, that is a very long time to be dealing with that kind of severe discomfort.
And critically, this isn't just a comfort issue anymore. The sources are so clear on this now. VMS symptoms are not just bothersome. They are an independent predictor of future health problems.
What kind of problems?
Well, a high VMS burden is linked to increased cardiovascular risk. Specifically, women with frequent hot flashes often show early signs of endothelial dysfunction, which is a risk factor for heart disease.
Wow.
And they also show increased bone turnover, which is a clear predictor of long-term bone loss and osteoporosis.
So treating the symptoms isn't just about feeling better in the moment. It might actually be about addressing a kind of biomarker for future heart or bone risk.
Exactly. And the consequences of not treating it are clear. A high symptom burden is tied to decreased mental and physical quality of life. It tanks work productivity, and it leads to huge increases in healthcare costs. This is a major public health issue.
Okay, so let's shift to diagnosis. This is what determines who gets treatment. For most people over 45 who come in with the classic symptoms VMS, amenorrhea menopause is a clinical diagnosis, right?
That's right. Lab tests, like checking FSH levels, they're generally not needed unless the doctor suspects something else is going on. The very first step, always, is to rule out pregnancy.
But that all changes if there are red flags or if the patient is much younger. What are those atypical presentations that mean you have to do a much deeper workup?
Well, if the VMS are unusual, say they're accompanied by really profound flushing or sweating or palpitations that just seem out of proportion,
Hmm.
or if they're tied to other systemic symptoms, you absolutely have to investigate. You have to rule out things that can mimic VMS, and some of them are quite serious.
Like what?
Things like carcinoid syndrome, which releases vasoactive substances, or pheochromocytoma, which causes these massive hormone surges. You even have to consider some malignant diseases. Missing those means you're delaying critical care for a totally different illness.
And then you have the really specific case of premature ovarian insufficiency, or POI. This is menopause before the age of 40.
And it affects a significant minority, between 1 and almost 4% of women globally. For this group, the diagnostic approach is completely different.
Why is that? Why so different?
Because the biological stakes are just so much higher for them, they're losing their natural hormonal protection decades earlier than they should.
Right.
So for any patient under 40 with irregular cycles and menopausal symptoms, a complete workup is non-negotiable. That means testing FSH and serum estradiol to confirm ovarian failure and ruling out other genetic or endocrine causes. The urgency is all about getting those hormones replaced immediately to protect their long-term heart and bone health.
Okay, so let's pivot to the core treatment guidelines.
Yeah.
Because despite all the noise from the past, current international medical societies are, they're completely unequivocal. MHT is the recommended first-line treatment for moderate to severe VMS.
Yes, in both menopausal and perimenopausal patients, assuming, of course, there are no contraindications. The efficacy data is just incredibly powerful. MHT isn't just a little bit helpful. It reduces the frequency and severity of hot flashes and night sweats by about 75% across the board.
And if you zero in on the women who are categorized as having moderate to severe symptoms, MHT can improve things by as much as 90%. That's life-changing. It's a transformative impact on sleep, on quality of life, on your ability to function.
It absolutely is. And the mechanism is really a two-part system depending on the patient's anatomy. The estrogen part is the key. It's what provides the symptomatic relief.
How does it do that?
It stabilizes the thermoregulatory center in the hypothalamus, which is the part of the brain that's kind of going haywire during VMS. But, and this is crucial, if the patient have a uterus, the second component of progestin is absolutely essential.
Okay, so why is that progestin so critical for someone with a uterus?
Because unopposed estrogen, so estrogen without a progestin to balance it, causes the lining of the uterus, the endometrium, to just keep growing and thickening. That condition is called endometrial hyperplasia, and it's a major risk factor for developing endometrial cancer. The progestin protects the uterus. It stabilizes the lining and prevents that overgrowth, neutralizing the cancer risk.
Now let's get into formulation and delivery, because this is where the science has gotten so much more sophisticated. We have oral pills, and we have transdermal options like patches and gels. And the consensus now really seems to favor transdermal in a lot of cases.
It does, and we need to unpack why the delivery method matters so much for safety. This is where understanding biochemistry can literally save lives.
Okay.
When you swallow an oral estrogen pill, it's absorbed through your gut and sent straight to the liver. This is called the hepatic first pass effect.
And the liver is what, like a factory for clotting factors?
Exactly. It produces things like fibrinogen and factor VII, which are critical for blood coagulation. When a high dose of oral estrogen hits the liver directly, it acts as a powerful stimulus.
So it revs up production.
It revs up production of the procoagulant factors, and at the same time, it reduces the synthesis of anticoagulant factors.
Nice.
This whole shift creates what we call a hypercoagulable state.
A state where your blood is just more likely to clot.
Precisely. And that, right there, is the primary driver behind the increased risk of VTE, venous thromboembolism, that we see with oral MHT.
So by choosing a patch or a gel, which gets absorbed through the skin, you bypass that whole process. You avoid that big initial rush of estrogen hitting the liver.
Exactly right. Transdermal estrogen gives you much lower, much steadier hormone levels, and crucially, it does not trigger those same changes in the liver. This is why all the recent big meta-analyses show that transdermal delivery has a significantly lower, maybe even negligible risk of VTE and stroke compared to oral.
And beyond the standard pill or patch, the sources also point to some newer, more advanced formulations. TSECs, tissue-selective estrogen complexes. How do they fit in?
These are really exciting alternatives. They combine conjugated estrogen with an agent like basedoxifene. You can think of them as designer estrogens.
How so?
Because they're designed to selectively turn on estrogen receptors in some tissues, like bone, but block them in others, like the breast and the endometrium.
So it's a single pill that gives you the relief from the estrogen, but it protects the uterus without needing a traditional progestin.
Exactly. So you avoid the side effects and potential risks that come with the progestin component entirely, while still getting that important bone density benefit. The data shows TSECs are linked to less breakthrough bleeding and less breast tenderness. Those are huge quality of life improvements.
Well, let's talk about duration and dose, because historically this was so rigid. The old mantra was lowest dose for the shortest time. Has that softened?
Thankfully, yes. It's become much more flexible. The duration is no longer rigidly capped at 5 years for everyone. The modern guideline is all about treating symptoms with the safest regimen for as long as the symptoms last, and the benefits outweigh the risks. It demands constant, individualized evaluation.
And the dosing for the POI population, the women with premature menopause, is a perfect example of this.
Absolutely vital. For patients with POI, the goal shifts. It's not just symptom relief, it's hormone replacement to prevent really severe long-term diseases like osteoporosis and heart disease.
So they need to stay on it longer.
They should continue hormone replacement until at least the average age of natural menopause, which is 51, and that's regardless of whether they're still feeling hot flashes. And the sources are very clear. The doses for patients with POI should actually be higher than standard doses to ensure they get enough protection for their bones and heart over that much longer time frame.
Here's where it gets really interesting. We have to talk about the Women's Health Initiative, the WHI trial. It completely changed medicine, caused this massive disruption. But the sophisticated reanalysis since then has just fundamentally redefined the benefits and risks. Let's start with the clearest benefit, bone health.
The benefits for the skeleton are just. They're indisputable. They were proven even in the original WHI trial. MHT consistently and robustly reduces the incidence of osteoporosis-related fractures. It's a major protective factor.
The numbers from the WHI on this are staggering. A 34% reduction in hip fractures, 34% in vertebral fractures, and 23% in other osteoporotic fractures. I mean, just think about what a 34% reduction in hip fractures means for someone's independence and longevity. It's monumental.
It's a critical finding, especially when you realize MHT is often considered a second-line treatment for osteoporosis. But for a woman who is also suffering from debilitating VMS, MHT is a single solution for two huge health risks.
And beyond the bones, you see these improvements in just general well-being. MHT controls the night sweats, which leads to profoundly better sleep. And it helps with the mood disturbances that are so common in perimenopause.
We also see positive metabolic shifts. MHT can improve your lipid profile. It increases HDL, the good cholesterol, and decreases LDL. And some data suggests it might even reduce the risk of type 2 diabetes.
That diabetes link is interesting. Does the formulation matter for these metabolic benefits like it did for the clot risk?
Yes, and this is another one of those crucial nuances. The primary metabolic benefits, like the changes in lipids, are seen predominantly with oral estrogen.
That seems counterintuitive given what we just said about clot risk.
It is, but it's a direct consequence of that same hepatic first-pass effect. The estrogen passing through the liver alters how it makes various proteins, including lipoproteins. So if a doctor is prioritizing metabolic goals and the patient has very low VTE risk, they might actually lean toward an oral formulation.
Now, for the most contentious issue of all, cardiovascular risk. The WHI suggested MHT increased heart risk, but now everything is viewed through the lens of the timing hypothesis. Can you explain why the when is so much more important than the what?
The timing hypothesis states that MHT provides cardioprotection, but only when it's started during a specific window of opportunity. That window is before age 60 or within 10 years of the final menstrual period.
Okay.
The key insight is that estrogen seems to be protective for healthy arteries, but it might actually be harmful to arteries that are already diseased.
So if you start MHT early, your arteries are likely still healthy, and the estrogen helps maintain that health, reducing plaque buildup.
Correct. But the original WHI enrolled a lot of women who were older, many in their late 60s or 70s, and decades past menopause. By that age, many already had existing subclinical plaque in their arteries.
And so when a patient with that existing unstable plaque starts hormone therapy, what happens?
It might trigger inflammation or promote a clot to form right on that plaque, and that could precipitate a heart attack or a stroke. So the WHI's negative findings for older women didn't mean MHT was bad for everyone. It just meant it's not a good preventative drug for women who already have established heart disease.
And all the current data supports this. It consistently shows MHT started in that optimal window is linked to reduced coronary artery disease events and even a reduction in overall mortality. It completely flips the original fear on its head.
It just reinforces that you have to look at the patient's age and how long it's been since menopause first and foremost.
Let's move to breast cancer risk because that is probably the single biggest source of anxiety for patients. What's the precise finding on combined MHT?
For combined MHT, that's estrogen plus a progestin, the WHI did show an increased risk, a hazard ratio of 1.2. But you have to put that number in context. You have to look at the absolute risk.
Right.
For a typical woman aged 50 to 59 who starts MHT within 10 years of menopause, the increase is estimated at only 3 additional cases per 1,000 women using combined MHT over 5 years.
That's a very small absolute increase. For someone suffering from severe symptoms, that tiny risk has to be weighed against a profound improvement in quality of life and a huge reduction in fracture risk.
And this is where the type of therapy matters so much. If a patient has had a hysterectomy and only takes an estrogen, the data changes completely. The WHI 20-year follow-up found that women on estrogen alone actually had a lower risk of breast cancer than women on placebo.
A lower risk? That's incredible.
It is, and it strongly implies that the progestin component is the main driver of the increased risk we see in combined therapy.
So does the chemistry of that progestin matter? Is one type different from another?
It matters intensely, and this is a point that gets missed all the time. You have to distinguish between synthetic progestins, like the one used in the WHI, and micronized progesterone.
Okay.
Synthetic progestins are man-made and structurally different from the body's natural hormone. Micronized progesterone is chemically identical or bioidentical to the progesterone your ovaries make.
And they interact differently in the breast tissue.
Yes. And because of that, a growing body of research strongly suggests that using micronized progesterone may carry a lower risk of breast cancer than many synthetic progestins. This has become a huge factor in prescribing today.
Finally, let's just circle back to the risk of stroke and blood clots, VTE.
The overall risk of VTE is roughly doubled, mostly in the first year of use. But again, it's all about timing and the route of delivery. The stroke risk is overwhelmingly concentrated in older patients, those over 60 who start MHT more than 10 years after menopause.
But for women under 60?
The absolute risk is tiny, about 2 additional strokes per 10,000 person years.
And the transdermal route is the big mitigation strategy here.
Absolutely. The data is solid on this. Transdermal estrogen, the patches, the gels, is consistently associated with a significantly lower VTE risk compared to oral because it avoids that whole liver first pass effect. For any patient with existing clot risk factors, transdermal is really the only way to go. If we connect this to the bigger picture, all of this nuance we've just unpacked, the critical role of timing, formulation, the delivery method, it just makes it impossible to justify a one-size-fits-all approach anymore.
It has to be a highly individualized equation.
Exactly. Balancing risk against the severity of the symptoms and the patient's own health goals.
So when a doctor is designing an MHT regimen for a new patient, what are the primary factors they're considering beyond just stopping the hot flashes?
They have to systematically weigh the patient's intrinsic risk profile. Do they have a family history of breast cancer, a history of VTE or stroke? And then they look at their anatomy. Do they have a uterus or not? That determines the first choice. Oral versus transdermal, and combination versus estrogen only.
Okay, so we know patients with VTE risk factors should get low-dose transdermal therapy. What about those with breast cancer risk factors?
For them, the clinician needs to choose regimens that minimize that progestin-driven breast risk. That might mean using a TAC, or if they need combination therapy, choosing cycloprogesterone over a continuous synthetic progestin.
This brings us right back to that critical trade-off we mentioned. For a patient with a uterus, the progestin is essential to prevent endometrial cancer. But the synthetic progestins are the ones tied to the higher breast cancer risk.
That's the dilemma. And while micronized progesterone seems to be safer for the breast, some clinical data suggests it might be slightly less effective at fully protecting the endometrium compared to some of the more potent synthetic progestins.
So the doctor's in this tough spot. Choosing the option with the best uterine protection might carry a slightly higher breast cancer risk. Choosing the option that's safer for the breast might have a slightly lower confidence level for full uterine protection.
The decision often comes down to a deep conversation about the patient's specific risk of uterine cancer versus their personal anxiety and risk factors for breast cancer. It requires shared decision-making.
This individualized approach really finds its most powerful use when we look at high-risk populations, specifically women with the BRCA gene mutation. This is a fascinating paradox.
It's a critical area where all the general assumptions just fall apart. Women with BRCA1 or BRCA2 mutations have extremely high lifetime risks for breast and ovarian cancer. Many of them choose to have their ovaries and fallopian tubes surgically removed to reduce that risk.
Right, sometimes in their late 30s or early 40s, so they trade the high risk of cancer for an instant, severe surgical menopause.
And for years, the immediate impulse for any clinician was to refuse MHT for them because of that high baseline breast cancer risk.
It seems logical.
It does. But a recent matched prospective analysis of BRCA carriers just completely challenged this. They found that MHT use was not associated with an increased risk of subsequent breast cancer in this specific group.
That's incredibly counterintuitive.
Yeah.
Did they break it down by formulation, given what we know about estrogen only being safer?
They did, and the results were even more startling. Women who had the surgery and then received estrogen-only MHT were found to be 63% less likely to develop breast cancer than their counterparts who didn't take MHT.
Wow, a 63% reduction.
And get this, of the 43 women who received the TSCC formulation, that designer estrogen, none of them developed breast cancer during the follow-up period. 0.
That completely changes the calculation for this group. It suggests the MHT is just replacing the hormones that were surgically removed, which mitigates the awful health consequences of early hormone loss without actually accelerating their underlying genetic cancer risk.
Exactly. It's a profound implication. For certain high-risk groups, MHT isn't just safe for managing surgical menopause. Some formulations might even be protective.
Beyond genetic risk, clinicians also have to manage the more common side effects of MHT. What are the frequent complaints?
The most common are unexpected vaginal bleeding, mastalgia or breast tenderness, and headache. Unexpected bleeding is always a concern. If it persists beyond 4 to 6 months, it needs a full investigation with an ultrasound or endometrial sampling to rule out hyperplasia or cancer.
And the breast tenderness.
That's a common estrogenic side effect. It often improves on its own after 3 or 4 months. If not, you can manage it by lowering the estrogen dose or switching to a TSCC, which is known for having lower rates of it.
What about patients who also have migraines? Is MHT off the table for them?
No, migraine is generally not a contraindication. In fact, for many, keeping a continuous, steady dose of both estrogen and progesterone can stabilize those hormone fluctuations and actually improve their headaches.
Okay, let's turn to the current regulatory and media landscape. The FDA recently removed the black box warning from MHT packaging, which was a huge deal. But there was some significant controversy around how that was framed.
This takes us right to the sharp, critical assessment of the media claims. One expert, Dr. Jen Gunter, actually called the editorial that announced the removal propaganda.
Wow.
And her critique wasn't about the removal itself. It was about the fact that the editorials promoting it were referencing low-quality, often pre-WHI observational data to make these huge, sweeping claims of benefit.
What specific claims were seen as exaggerated?
The claims that MHT reduces all-cause mortality or that it provides this massive protection against dementia, those claims are just not supported by the rigorous randomized controlled trials we have. The argument is that MHT is fantastic for symptoms and bones, but it shouldn't be sold as a preventative medicine for everything based on weak evidence.
This connects directly to the healthy user bias, which is so important for understanding why those older observational studies were flawed.
It is. Healthy user bias is a major problem in non-randomized studies. Think about it. 30 years ago, the women who chose to take MHT were generally the ones who were more proactive about their health. They had higher socioeconomic status, they didn't smoke, they exercised more. They were just inherently healthier to begin with.
So when you compare them to the non-user group, of course they look like they had better health outcomes. It wasn't necessarily the drug, it was their healthier baseline.
Precisely, and we saw proof of this. Before the WHI, MHT users did have lower all-cause mortality. But after the WHI results scared everyone, and many of those healthy women stopped taking it, the data showed that MHT users no longer had lower all-cause mortality. That suggests the benefit was the bias, not the medication.
Which reinforces the professional consensus. MHT is for managing moderate to severe symptoms or high osteoporosis risk, not as a blanket prescription for preventing diseases like dementia.
Absolutely. Patients shouldn't start MHT hoping to prevent cognitive decline. The data just isn't there.
So for patients who have absolute contraindications to MHT, or who just prefer not to use hormones, what are the non-hormonal alternatives?
The non-hormonal options are generally less effective, maybe a 50% symptom reduction compared to MHT's 75 to 90, but they're necessary. The mainstays are certain SSRIs and SNRIs.
The antidepressants.
Right, because they also act on central thermoregulation in the brain. Things like gabapentinoids can be particularly good for nocturnal symptoms for night sweats.
And this leads us to the most exciting new development, a non-hormonal solution that acts directly on the brain's temperature center.
This raises an important question. What knowledge gaps still remain? This new class is the neurokinin 3 receptor antagonist, like fezolinetant. They are a fundamental shift in how we approach this.
How does that mechanism work?
It acts directly on the KNDI neurons in the hypothalamus, the brain's thermostat. In menopause, the lack of estrogen destabilizes the center. These new drugs restore the sensitivity of that thermostat.
So it's a true non-hormonal mechanism. It's not touching estrogen receptors anywhere else in the body.
Exactly, and this is helping us answer some of those big remaining questions. We can finally start to figure out if the secondary benefits we see with MHT, like bone protection, are solely due to estrogen, or if they're partly just a happy side effect of getting better sleep and reducing stress, which these new drugs also achieve.
As we look forward, what are the biggest unanswered questions that future research needs to tackle?
We really need definitive long-term data on the optimal duration of treatment. How long is truly safe and beneficial? We also need head-to-head trials to figure out which specific hormonal formulations are truly superior for minimizing risk while maximizing protection. And finally, we need to see if these new non-hormonal agents offer any long-term protection for the heart or bones. #outro.
So this deep dive has really confirmed that MHT is still the first-line most effective treatment for VMS. For you, the listener, the key takeaways are all about nuance. Timing is critical start before 60 or within 10 years of menopause. Transdermal is safer for clot risk than oral. And if MHT is not for you, there are promising non-hormonal alternatives.
And that revelation about the BRCA mutation carriers, that certain MHT regimens can be safe and maybe even protective for them, that's probably the most powerful example of why you can't apply broad risks from a general population to a specific targeted group.
So what does this all mean? It means you have to be an active, informed advocate for your own health. You have to question the broad claims, both the exaggerated promises of prevention and the generalized fears of risk, and focus on your individual symptoms, your timeline, and your precise risk profile. Throughout our discussion, we kept coming back to the complexity of choosing a progestin. For patients who need uterine protection, you have synthetic progestins and micronized progesterone. They both do the job, but they have that known trade-off.
Right. The synthetic progestins are linked to that slightly increased breast cancer risk from the WHI, while the micronized progesterone might be a little less consistently effective at preventing all forms of endometrial hyperplasia.
That tension balancing uterine protection against minimizing breast cancer risk is a daily clinical challenge. So we'll leave you with this final provocative thought to consider. Given those known differences, what specific criteria should doctors prioritize when choosing between a synthetic progestin versus micronized progesterone? Does a patient's personal qualitative anxiety about breast cancer, even if their absolute risk is low, override the need to maximize the quantitative protection against uterine cancer? How much should a patient's emotional response factor into that final critical decision? Think about the weight of that choice as you continue your own deep dive.
Thanks for listening today. 4 recurring narratives underlie every episode: boundary dissolution, adaptive complexity, embodied knowledge, and quantum-like uncertainty. These aren't just philosophical musings, but frameworks for understanding our modern world. We hope you continue exploring our other podcasts, responding to the content, and checking out our related articles at helioxpodcast.substack.com.